Transplantation for children is very difficult. Everybody wants to have small incision. Great question, thank you very much. And I completely agree with you. Cardiac surgery image for a majority of population, it is what you tell, big incision, a lot of blood, and terrible. Human body is unique. Maybe in the future, in 100 years, all procedure will be done by robotic.
Yeah, we know.
But not now.
Yeah. But human touch is yes, always different.
But not now.
I agree.
I'm sure. If we discuss about robotic and endoscopic approach, it's also very common procedure now in Germany. But you need for this procedure trained team and huge experience.
Yeah, the baseline is you can repair a heart without actually opening up.
Yes, exactly.
Welcome to Blue Dot Podcast. I'm your host, Dr. Mohammed Afsal, Medical Director and Flight Physician for Blue Dot Medical Assistance and Blue Dot Air Ambulance. Here we are going to discuss about the innovations in medicine, the goals to recovery, and the future tech which we have to know in the future and in the present. Imagine this. You are an aeromedical team who is transferring patients across the globe, a critically ill patient, and their life hinges on one decision: where to take them. I have come across this question and I have seen families choosing one location in specific, Germany. Why? Today we are going to dive deep into that question with our guest, Dr. Sergey Leontyev from Helix Private Clinic. He is one of the world's leading pioneers in cardiovascular innovation. So, Doctor, welcome to our podcast. If you can introduce yourself to our audience, please.
Thank you very much for this invitation. It's for me a great pleasure to be here in Dubai, and I'm Professor Leontyev. I'm from Heart Center Leipzig. It is the largest hospital, cardiac surgery and cardiology hospital in Germany, and we performed all spectra of cardiac surgery procedure. Have a huge experience in treating different patients also from these countries, and it is great pleasure to discuss different topics today with you.
Thank you, Doctor. So, let's talk the discussion. As in a decade, as a flight physician, I have seen this pattern where families in this region often bypass their own hometown or their own country for that matter and chooses Germany. Why is it so? Is it the technology or is it the expertise, the innovation? So why it is?
I believe it is a lot of different points. First, it is, in my opinion, medical experience and reputation. Germany have a lot of good hospitals and large institution with a lot of experience in treating patients with oncology, cardiology, neurology. And we used advanced technologies and innovation always in treating of our patient. German hospital have a lot of experience in advanced diagnostic robotic surgery and also experimental treatments of different diseases. In my opinion, in our point, it is efficiency in structured health care system, which is known in all world. We in our hospital are very sufficient. We had a structured plan for each patient, and also we have a high patient succeed rates, and we tried always give our patient privacy in description, because of privacy, especially for patient with heavy disease, is much important. Some patients come with a whole family to us, and we organized everything to be comfortable in our hospital, in our clinic, and give best opportunities to this patient.
Great, that's fantastic. So let's drill into your specialty. So when people picture an open heart surgery, they picture a lot of blood, saw, cutting up the chest. But tell me how your team is like, going to drill into the chest and do all these procedures through a tiny hole. How you make that possible?
Great question. Thank you very much. And I completely agree with you. Cardiac surgery image for a majority of population, it is what you tell, big incision, a lot of blood, and terrible. But but now they have a lot of new opportunities to treat this patient. It is a minimal invasive approach, endovascular surgery, and robotic surgery. I mean, minimal. What is minimal invasive approach? It is small incision. In my opinion, everybody want to have small incision, and
Of
for
course,
us, it is the standard approach. It is a minimal invasive surgery for a heart valves. It is a mini thoracotomy. It's small incision between ribs. Mini sternotomy. It is only 5 or 6 centimeter skin incision in the middle of sternum. And in spite of this small incision, we can repair or replace a mitral or aortic valve or both valves without opening the chest. And for our patient, it is a huge advantage for recovery after surgery. Another opportunity is endovascular approach. You know, it's very common now, transcatheter operation for a patient with aortic valve pathology, mitral valve insufficiency, or tricuspid valve insufficiency. And for aortic valve, we have now transcatheter aortic valve implantation. We do this surgery under local anesthesia. Under local anesthesia, I can speak with patient during procedure, and we put the valve, we puncture vessel in the groin, put device in the body, deploy the valve, and after surgery, patient can walk around in the evening.
That would be
compared to open heart surgery. We need intensive care, we need intermediate care, and the recovery of patient in this case, it's about 2 or 3 days compared to minimal to transcatheter aortic valve implantation. It's only 1 day.
Yes. That's very important. The recovery period. Nobody wants to be in a hospital for a long time.
Sure, and patient can be discharged 3 or 4 days. But this surgery is not for all patients. The same is for endovascular mitral valve repair, mitral clip or Pascal implantation for mitral or tricuspid valve. We do this under anesthesia. We put a device in the groin and perform reconstruction of mitral valve under X-ray and echocardiography guiding. It is no procedure. It's for a high-risk patient, but it's a huge advantage also for a patient with end-stage valve pathology. If we discuss about robotic and endoscopic approach, it's also very common procedure now in Germany, but you need for this procedure trained team and huge experience.
Yes, I can only imagine. But yeah, the baseline is you can repair a heart without actually opening up.
Yes, exactly. I completely agree with you.
Okay, so is there any case, a specific case, if you can like mention where a minimally invasive surgery was the only option for, like, instance, a patient who was too frail for a conversion surgery?
Absolutely. Absolutely. I told you we have large experience in transcatheter aortic valve implantation. We have about 1,000 cases a year only for this procedure in our hospital, and 300 cases for mitral clip implantation. and tricuspid. And if we discuss about patient with aortic pathology, a couple of weeks ago, we have an old lady coming from GCC with severe aortic valve stenosis. And she had advanced diabetes, she had kidney disease, COPD, history of stroke. It is a high-risk patient.
It is,
We
of
can do,
course.
and you can decide do open heart surgery or transcatheter aortic valve implantation. And for this lady, after heart team discussion, we decided to do transcatheter aortic valve implantation. We inserted catheter through a small puncture in the femoral artery in the groin, put our device, deployed the valve, and after 5 days, this old lady was discharged. And in my opinion, for this patient, it was only one opportunity to survive.
That's
Yes.
fantastic. Yeah. So these are the options that the patients
Yes.
actually need at those times.
Yes.
Especially in those patients with all the comorbidities that you can ask for. But then we put that question in the other way. When do you say this patient needs a traditional surgery like the open? Like, are there conditions where minimally invasive surgeries are not possible?
I'm sure open heart surgery still actual, and we cannot and we cannot treat our patient without open heart surgery. And we have a lot of patients with complex multivalve disease, and endocarditis also, with infection of the valves in the heart. It is, in my opinion, absolutely indication for open heart surgery. Or if you have some patient with extensive coronary artery disease,
Yes,
a
of
complex pathology of coronaries, it's very difficult to treat this patient minimal invasive, especially with poor left ventricle function. And our point is aortic disease. Yes, we have a large program for aortic disease, and we have also a lot of patients with acute aortic dissection. And if you know this patient, it's a great advantage to treat this patient. And this is only one way: open completely, make a full sternotomy, open the chest, and treat this patient, operate this patient. And for young guys, because if we discuss about transcatheter approach, now we have a follow-up experience. If you look for publication, about 5, maximal 10 years. And if you have a young patient, 30 years old, active, you cannot suggest him to perform endovascular approach. It is better to perform open heart surgery. You can do both open heart surgery or minimal invasive heart surgery, but especially for a young, healthy patient, we perform open surgery, minimal invasive surgery, and not endovascular valve implantation or valve repair.
So now we talked about the patients who can get it and who cannot. Now let's talk about the operators, the surgeons. Seems like these techniques demands, an incredible skill set. So how do you train your surgeons to work through ports instead of the direct vision? Do you have definitely you'll be having your trainings and all, but I'm asking what more do you do? Do you have any simulators or something like that?
Thank you. It's a great question. To train young surgeons is very important. And in our hospital, we try to train our surgeon in 2 ways: for endovascular procedure and also for minimal invasive and open heart surgery. And we have in our clinic all opportunities, and in Germany, in large hospital generally. And for a transcatheter approach, transcatheter aortic valve implantation and mitral valve. We have a 3D trainee simulator, and young colleagues can train every day, whole day, in the night, during the night, and it is always possible. For endoscopic and robotic surgery, we have also simulators, and it's helped us as experienced surgeon and also for young colleagues to be up to date in this field. Wet labs and cadaver training, it's always possible. We have a large animal laboratory in which we can organize wet labs for different kinds of surgery, beating heart surgery, minimal invasive surgery, and also cadaver training and university can be also done, and proctoring.
Great.
C1
Looks like a lot of
one,
training
each
into
one,
this.
yes.
Yes.
It's still actual.
Yes. So the next question, I cannot hold back in this era of AI and technology and robots. So I've heard whispers about AI guided catheters and all. So are we nearing a future where such procedures also can be done autonomously by robotic surgery?
I'm not sure.
Okay.
because
That's respectable.
as a surgeon, I still believe in the future we will need surgery hands. I'm sure artificial intelligence now gives us amazing opportunity to create everything. You can create paper in 10 seconds. You can create presentation, but human body is unique, and you have to understand how you will do this special procedure, how you can treat this special patient. And maybe in the future, in 100 years, all procedure will be done by robotic.
Yeah, we know.
But not now.
But human touch is always different.
But not now.
I
Yes,
agree.
I'm sure.
Now let's talk about the other expertise, the artificial hearts, a concept that looks like straight out of a sci-fi movie. So your team implants an artificial heart as a bridge to the regular normal transplant. So just walk us through that journey, because this is something new for most of the people.
It's a very important topic, and thank you for your question. Treatment of a patient with heart insufficiency is very difficult and important, because for understanding, we treat patients who cannot survive without our help and can die very soon. And if I have some indication for artificial heart implantation, left ventricle assist device or total artificial heart, I mean, it is a huge step to save a life of the patient. And we can do this for bridge to transplant, bridge to recovery. We have some patient, especially older patient, it is like a destination therapy. Now we have new devices. We have a huge experience in treatment of this patient, and we have more and more patients with heart insufficiency who need treatment with artificial heart.
Okay, great. So as a flight physician, we as the company Blue Dot have transferred a lot of children with cardiomyopathy across continents just for the transplants, and most of them are on ECMO supports. So this transplant, this artificial transplant as a bridge to the conventional transplant, can it be done in children as well, pediatric population?
Very difficult topic, because transplantation for children is very difficult. In Germany especially, because of a donor situation. We have some experience of treatment this young patient with artificial heart, But treatment change in children with artificial heart is very difficult because of size consideration. You have a young, you have a children with a very small body, and you have to put and connect this artificial heart with the heart, and it's not so easy. In our point, children still growing, and we can, for adults it isn't a problem, but for a children you put some device and a child still growing, and it could be a problem in the future. And bridge to transplant, if you put some artificial heart in such young patient children, you have to understand what you do this patient in your future. And transplantation program for children in Germany, it's not so common. It's clear, it's a known problem, but we try to help our patients.
Yes, for sure, because transplant is not an option in many of the places that you rightly mentioned. So that takes me to the next question. So again, from our experience, we have seen patients who has been on an ECMO machine as a bridge for transplant. They have a failing heart, now they are on ECMO machine. Now they has to travel, to other continents for that matter, like 10 hours, more than 10 hours on ECMO, on an aircraft, which is being very risky. So I have even seen patients on an ECMO more than 100 days just for waiting for a heart. For those patients, will this artificial lung can be, much more helpful when we can like reduce the risk of an ECMO, the complications of an ECMO, and then keep them on this artificial heart. So the question is, will that help a patient take off the load of the ECMO and the complications?
Thank you. Firstly, it is amazing what you do. Transfer patient with ECMO in all
Thank
over
you,
the
Dr.
world,
Yes.
airplane. It's very difficult. It's very difficult, and you need a lot of experience in patient ECMO devices. It's amazing what you do. But we have experience treat patient coming to us with ECMO, and if patient come to us with ECMO, we have to decide, and we have basically three ways to remove ECMO or to wean ECMO, to put some artificial heart in this patient, and or decide to longer ECMO therapy if we can see a recovery of the heart and potential of this patient. It's mean patient, for example, patient with myocarditis. Yes, it's still sometimes months to recovery, but after this time we can wean ECMO and remove ECMO. And but for understanding ECMO therapy, it's very complicated because of common complication like bleeding, lytic
Yes,
clots,
of course, a lot of
and
complications.
the treatment of this patient is very strange, but it's always possible.
That's a hope for like patients who is dependent on ECMO and waiting for that heart, which is going to arrive after weeks or months for that.
Yes, exactly.
But with every mechanical device, this also the artificial lungs also can come with failures or mechanical failures. So what will be your backup plan if already implanted artificial lung fails? Is there any override, or can we like keep them back on an ECMO? Or
It's depends of situation. Yes, and if a patient have a problem with his artificial heart and still in normal status, and still cardiopulmonary stable, we can prepare operation, and we can change artificial heart. We have, I believe, last year we have 2 or 3 cases in which we have to change artificial heart. But if a patient is not stable and have a cardiogenic shock, we have to put this patient on ECMO, prepare surgery, remove the old artificial heart, put a new artificial heart, and it's helped us to recover patient and save the life.
So let's just zoom out from the core, this complex things, and let's just touch upon one base. I've seen a lot of patients arriving with, a lot of complex comorbidities, maybe due to late referrals or other, hospital acquired infection, you name it. But what is your approach for those patients who come with a lot of complexities rather than their exact condition?
Firstly, we have to understand. We have to take care. If we have acute situation, we have take care of this acute situation, and we can start our therapy, and we have to perform rapid stabilization and acute care of this patient. In such cases, we need an ECMO. They have some patient from Kazakhstan, for example, who come to us with normal pain, but after a couple of hours, it's come to rapid decompensation of cardiac function. We put him on ECMO. After a couple of days, we perform very complex surgery, and patient survive. It was 10 years ago. I know this case very clear for me was without ECMO, without rapid stabilization, we don't have any chance to help him. After this rapid stabilization, we need an advanced diagnostic. So we have all opportunities, echocardiography, MRI, CT scan, diagnostics. And after this advanced diagnostic, we can plan our treatment for each patient. And after this diagnostics, we can decide. It could be aggressive medical therapy, device therapy, or standard cardiac surgery. It's always depend how patient come to us.
Yes, a tailor-made
Yes.
Plan for
Yes.
each patient. Yes.
But all patients will be treated in our hospital after with heart team. We decided always together with our cardiology, arrhythmology department, and we have a large department of children cardiology and cardiosurgery in case of pediatrics, but it's always a heart team decision to find best therapy option for our patient.
So, doctor, all this time we were talking about, traveling to Germany, to Leipzig, and get your expertise for treatment. But as I was mentioning, traveling with a patient with, that much complexity is not always a good choice, but we have to do that. So, what if your team and your expertise and all these technologies can be utilized over here in ground zero, as in Dubai? Can you do that over here? Do you need more team or expertise or infrastructure?
Thank you very much. It's a very important question, especially for Dubai. In my opinion, Dubai have everything. Very modern hospitals, a team with expertise, and we can bring our experience from Europe here and treat patients also here in Dubai, because I told you all devices are here, and we can do here very complex modern surgery, also minimal invasive surgery, and transcatheter approach. And I know some clinic already started this program with a small number of patients, but it's possible. And for me, I can imagine to start here some practice also.
It's really good to know that it can be possible here itself, to avoid that hassle of travel and the complexities behind it. So my last question will be regarding the future. So let's say in 10 years, where do you see this minimally invasive and endovascular cardiac innovations?
Thank you. I believe in 10 years we will have more minimal invasive surgery, more minimal invasive approach, and especially transcatheter or robotic. But open heart surgery is still very actual, especially in complex cases. And I hope in 10 years we will have new devices, smaller devices, more efficient devices for artificial heart or as artificial heart to help our patient with heart insufficiency.
Thank you, Dr. Leontyev. So thank you for illuminating into this art and science behind cardiovascular innovations. It was truly insightful and informative at the same time.
Thank you very much for this discussion. It was a great pleasure for me to be here and discuss with you about our opportunities in treatment of patients with cardiac problems. Thank you very much.
To our listeners, if the session feels like a masterclass, it indeed was. As we all know, the technologies in healthcare and in any field for that matter is going to develop and continue, and our idea is to keep up with that pace and keep our audience also in that loop of technologies and the future. Until we meet again, it's bye from my team from Blue Dot. Thank you.